We are live, ma'am.
Good evening, everyone. And myself, Dr. Ramya, Clinical Head Fertility Specialist at Oasis Fertility Center, Guntur branch. And I welcome you all for the Facebook live session. And today's topic is importance of the genetic evaluation in infertility. So, in this mainly we are going to deal both this male factors and also the female factors where we are where we evaluate this genetic testing in both the couple. So, infertility as a disease of the reproductive system, which is defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. So, as we all know, infertility may be related to a female factor only or male factor or combined both the male and female factors together. So, first, mainly coming to the male factor. So, what is the importance in dealing అంటే మెయిన్గా అసలు లైక్ ఈ జెనెటిక్ టెస్ట్ చేయడం వల్ల వాట్ ఈస్ ద అబ్నార్మాలిటీ వై ఇట్ ఈస్ ఇప్పుడు మేల్స్లో దెర్ ఈస్ అజోస్పర్మియా ఆర్ ఆలిగోస్పర్మియా వై ఈస్ ఇట్ దేర్ సో వీ కెన్ ఫైండ్ అవుట్ ఆర్ అసెస్ ద కాజ్ అండ్ ఆ సేమ్ కాజ్ ప్రొజెనికి అంటే నెక్స్ట్ జనరేషన్కి ఎఫెక్ట్ ఉంటుందా because if the same will pass to the progeny and whether we can at least risk progeny కి వెళ్ళకుండా ఫర్దర్ ఈ జాగ్రత్తలు ఏమైనా తీసుకోవచ్చా సో ఆల్ దిస్ క్యాన్ బి డెల్ట్ ఇన్ దిస్ in the male the fertility criteria include mainly if there is a normal spermatogenesis and complete maturation of the spermatozoa during the passage through the accessory organs of the reproductive system, and whether there is any obstruction or whether these accessory organs are patent or not, and whether there is adequate seminal fluid and ability. Means if there should be no erectile dysfunction or ejaculatory problems in the male person. So most frequent genetic causes of male infertility are the chromosomal abnormalities, and the second cause will be the cystic fibrosis transmembrane receptor gene, and the third one will be the Y chromosome microdeletions. Y chromosome is mainly chromosome related to the male persons. So any deletions occur in the Y chromosome may affect the even the progeny too. And the studies on the families of the infertile patients that suggest that the male infertility may have a familial component and an autosomal recessive mechanism of inheritance was suggested. So the main indications for the genetic testing in the male infertility, first thing will be if a male person comes and when we see or check the semen analysis, in the semen analysis, if we find it to if it is an azoospermia or a severe oligospermia, in these cases we can provide. I mean, we can help them with this genetic testing in the male persons. Even if the detection of the genetic alteration will not substantially change the treatment, genetic testing should be done for two reasons. One is to finalize the causal diagnosis, and second is to assess the genetic risk for the offspring in case of the successful treatment. So, and for these things, once we find the persons with the azoospermia or oligospermia, they should be subjected for the genetic testing, and proper genetic counseling is needed in these patients. So these are all the chromosomes. Like we, everyone knows that we have got this 23 pairs of chromosomes, and out of this, one is the sex chromosome. XX will be representing the female, and XY will be representing the male. If these are all the autosomes and these are the sex chromosomes, anything, even this autosomal chromosomal problems can occur, or in some cases X-linked or this Y microdeletions or this sex chromosome problems also can happen. So these are all the chromosomes what we usually check in the karyotyping, whether they have these autosomal problems or the sex chromosome problems. So first thing, these chromosomes, they can have these abnormalities, either the numerical abnormalities or the structural abnormalities. See, maybe if we see in the Klinefelter syndrome, there will be an additional XXY, the chromosome pattern. If you see like that, the number of the chromosomes may increase or the structure may alter. In such abnormalities can lead to the problems in the patients. So the prevalence of the chromosomal aberrations in this infertile men is around 10 to 15 times higher when compared to the general population, and it ranges between 2% and 16% with an increasing frequency of abnormalities of autosomes with decreasing sperm count. In the majority of the cases, the infertile patient is an otherwise healthy male and the chromosomal anomaly does not play any pathological role. However, men carrying a translocation, for example, have a markedly increased risk of inducing a pregnancy ending in a miscarriage or stillbirth or fathering a child with varying degrees of mental or physical retardation in case of this unbalanced chromosome set of the offspring. So, therefore, the karyotype analysis is indicated in this every infertile man with oligo or azoospermia, at least in cases of an abnormal karyotype, should be accompanied by the genetic counseling. So we will be having this balanced translocation and unbalanced translocation. In balanced translocations, we can even see they will be phenotypically normal, but genetical composition can vary. Same thing in unbalanced translocation, phenotypic variations also can be there. So that is what this karyotypic analysis helps us to assess the problem and to analyze whether the offspring will be affected. That is why the genetic counseling will be helpful in such cases. So first thing is this Klinefelter syndrome. Klinefelter syndrome, here the karyotype will be the 47XXY and also including mosaics are common among infertile patients and may be identified by the following features. So these patients will have reduced testicular volume, azoospermia, and gonadotrophin levels like this FSH, LH, testosterone levels will be very low, and varying symptoms of this hypogonadism, such as a feminine body constitution, such as a gynecomastia, may be seen in this Klinefelter syndrome patients. So this is how the karyotypic analysis looks XXY. So usually in the male, it should be XY. Here there is an extra X chromosome getting attached in the XY place. So that is how the chromosomal variation happens, and that leads to all these problems in the male person, in that affected male person. So these are the affected person: reduced muscle tone, gynecomastia, mental retardation. All these features we can observe. So Klinefelter patients are infertile due to azoospermia, and however, after the introduction, but these people have the chances in the ICSI, means by procedure of the TISA, though they are azoospermic from the testicular biopsy, sometimes will be able to retrieve the sperms. So such sperms, by the procedure of this IVF ICSI, we can use these sperms and help to make their offspring. Therefore, the possibility of the testicular biopsy or the TISA and cryopreservation of the tissue should be discussed upon the first diagnosis of the Klinefelter's syndrome, even without an expressed wish for conception at the time. See, means as the time passes on, even the few spermatozoa which the in the testis are there, they also in the due course we may not. But once when we, as early as if it is diagnosed, we should counsel such a patient for cryopreservation of the testicular tissue, means the sperms which are available in the testicular tissue, if you are able to cryopreserve in case if we get these sperms, and these sperms will be helpful for them for the IVF or in the ICSI conceptions later. The other one is the Y chromosome microdeletion. So this Y chromosome is basically mainly related to the male person, and so any alterations or any deletions in this Y chromosome. So mainly what we observe is the breaking points of the deletions are well characterized at five main microdeletions. One is AZFA, AZFB, and AZFC. Sorry, AZBC, AZBC in this again B2, B4, and AZFC. So these are all the main five breaking points in the Y chromosome microdeletions. These microdeletions of the Y chromosome are the rare, that is less than 80%. Most of these, this 80% will be involving only the AZFC deletion. So this AZFC is the most common when compared to the AZFA and AZFB deletions. In general, azoospermic men have a higher prevalence of microdeletion when compared to the oligospermic men, and complete deletions of this AZFA, AZFB are always associated with azoospermia. So, but when we find out the sub-analysis in these patients, whenever AZFC deletions are there are more chances to get the sperms from the TISA or TSA. Okay, so in general, TSA is possible in patients with AZFC deletion with a probability of recovering sperms of about 50%, but no sperm retrieval has been so far reported in the AZFA and AZFB deletions. So in this AZFC, so in a day, the patients, if this genetic evaluation, why it is important is when we find this Y chromosome microdeletion is there, but still when you have this AZFC, still they'll have a chance of sperm retrieval or sperm retrieval by TISA, and these sperms can be in turn used in these procedures of this IVF or ICSI. So that is how we can means the genetic counseling helps in these patients. Then coming to the congenital bilateral absence of vas difference, this is something related to the obstructive azoospermia. Whenever we find the patients with this obstructive azoospermia, in these patients, totally we see all the hormone profiles will be maybe normal, but still they'll have the azoospermia. In such cases, we can term it as obstructive azoospermia. And in case if we find these mutations in these patients, like CTF gene mutation, most likely this is an autosomal recessive, and we need to counsel for the genetic counseling how the inheritance pattern, and once we find this in the father, the female partner also need to get evaluated. So patients with this obstructive azoospermia are the candidates for the genetic testing of the mutations of CTFR gene, as they may have a congenital malformation of the Olffian ducts, which are the precursors of the vas deferens, epididymis, and seminal vesicles during the fetal development. So this hypoplasia of the epididymis or the seminal vesicles can accompany the congenital absence of the vas deferens. In contrast with this, patients with the Y chromosome microdeletion, these patients exhibit the distinct clinical features of azoospermia and decrease in seminal volume, decreased seminal pH, and markers of this epididymal and seminal fructose formation, everything may be decreased, but the hormone side, when you see LH, FSH, and the testosterone hormones will be normal in these patients when compared to the Y chromosome microdeletion patients. And the majority of the men with this obstructive cystic fibrosis, they will have the normal spermatogenesis will be found on the testicular biopsy. So these people are the most benefited with the testicular biopsy, and on histological evaluation or TSA, when we see surely will get sperms from these patients, which also confirms the diagnosis of this obstructive azoospermia, and thus these men have a high chance of fathering a child by ICSI. However, the risk of the child having cystic fibrosis is increased in comparison with the general population and can be estimated depending on the the CFTR mutation of the man and the carrier status of the female partner. So, as this is inherited in an autosomal recessive manner, in this autosomal recessive manner, if you see, this is an unaffected father, carrier father, and unaffected mother who is a carrier. But the same thing when it is coming to their offsprings, one out of these four children can remain unaffected, but one will be affected and other two remaining the carriers. This is when the homozygosity or heterozygosity of this mutation is known, when that is unaffected father. Uh, in this case, one affected father with an affected, so that is why the carrier status of the mother is important whenever we find the male patient with the congenital absence of the vas difference or the cystic fibrosis. So that how many, I mean, offspring, we can assess the affection rate in the offsprings once we know the carrier status of both the partners. The next one will be hypogonadotrophic hypogonadism. In this, the patients, all the patients will be having the low gonadotrophin levels. That means all the hormone profile, which we have this FSH, LH, and testosterone, all these hormone levels will be very low in these patients. And then the semen analysis, if you see, there will be most likely azoospermia in these patients. So these patients can present in the two types are there, with anosmia and without anosmia. So can present with or without anosmia. The later means without anosmia, we know we'll call it as a Kallman syndrome. So the first gene identified to be responsible for this phenotype was denominated is the Kallman and encodes for a protein of the extracellular matrix, that is the anosmin 1. Successfully, more genes were found to be mutated in the hypogonadotrophic hypogonadism with or without anosmia. So this mutation it can be carried out by an autosomal dominant inheritance or an autosomal recessive inheritance, or it can be an X-linked inheritance. But these patients, thereby limiting the number of genes to be screened in this hypogonadotrophic hypogonadism. But most likely in these patients, they tend to go for a donor sperm. That is why the karyotyping effect is not much useful in that patient. And then coming to this idiopathic infertility, chromosomal anomalies are found in about 7% men with idiopathic infertility. Some patients, they may have this spermatogenic failure, predominantly that may be either numerical or structural in azoospermic men, and translocations or inversions in the oligozoospermic men. Routine karyotyping of the men with the sperm densities less than 10 millions, even in the absence of other clinical presentations, is recommended because infertility is associated with the higher rates of aneuploidy in ejaculator or the testicular sperms and increased chromosomal defects in the ICSI offspring. So, though they may be, even this idiopathic, if we routinely see and when we see the semen analysis, the count when it is even less than 10 million, even in such patients, it is important to carry out the analysis. So that is what, when AZF for deleted sperms are available and used for ICSI, fertility defects or male offspring seem inevitable. In the male patients, in the Y chromosome microdeletions, and when we get sperms, though it may be AZC, the offspring can be affected, the male offspring in particularly. So the females will not be affected in that mutation. So genetic causes of this idiopathic infertility must be sought by systematic evaluation of infertile men, and affected couples must be informed about the implications of such diagnosis for assisted reproductive technology and their potential offspring. There is currently no indication for the individual gene analysis in the idiopathic infertility. So that is all regarding the male infertility. Now coming to the female infertility causes, PCO and this premature ovarian failure and recurrent pregnancy loss. This in the PCO mainly the thing is FSH receptor polymorphism genes will be seeing in few cases of the polycystic ovarian syndrome. Though when they are subjected to the gonadotropins, there will be no response from the follicles. So these patients will have the FSH receptor problems. In those patients alone, this is helpful, but this is not a clear indication, mere or sole indication to do a karyotypic analysis in all the polycystic ovarian syndrome. But in such cases, it will be helpful, and in few cases, they will have this OHSS. In all these cases, it is helpful, not as a routine measure in all the patients. And in cases of this recurrent pregnancy loss occurring in around 0.5 to 1% of the total pregnancies, this is defined as 3 or more consecutive spontaneous abortions before 20 weeks of gestation. Although the immunology based etiology underlying unexplained recurrent pregnancy loss has been demonstrated, the exact molecular and genetic mechanism are still poorly understood. Recent studies showed that particular immunological abnormalities and thrombophilic aberration might underlie in the recurrent pregnancy loss. Mostly, what we see is the antibody abnormality with this recurrent pregnancy loss, and approximately 25 to 51% of the miscarriages in women with a recurrent pregnancy loss are associated with the chromosomal abnormality in the fetus and the karyotyping of the abortus. And so, what are the products of the conception, whichever is getting aborted, the karyotyping of these products also will be helpful, should be performed to determine whether there is a cytogenetic reason in this recurrent pregnancy loss. Based on the equal frequencies of the abnormal test results found among patients with 2, 3, or 4 or more recurrent pregnancy loss, suggest that a complete evaluation of evidence-based factors, that is parental karyotyping. And second thing is any uterine anomalies are there. The antibody testing like lupus anticoagulant and anticardiolipin antibodies, factor V agent and TSH should, in all these couples, these are all recommended. Caution must be exerted in the interpretation of an abnormal screening result, as the factor identified may not be the causative factor for the pregnancy loss too. Then coming to the final thing is the premature ovarian failure. So this premature ovarian failure is below the age of the 40 years. There will be this arrested folliculogenesis. It is defined as a primary ovarian defect characterized by the absent menarche. Maybe they may have the primary amenorrhea or premature depletion of the ovarian follicles leading to the secondary amenorrhea. So that is what is the premature ovarian failure. The causes of this premature ovarian failure are extremely heterogeneous, and the karyotype analysis should be performed in the primary amenorrhea and in cases of the premature ovarian failure at very young age. So, how this premature ovarian failure karyotyping helps us is, if we does as with the history of the patient's family history, if these people are subjected at an early age, we can help them to preserve their oocytes at least without any further delay. That is how this karyotyping helps in these premature ovarian failure patients. Karyotype analysis should be performed in the primary amenorrhea, and in cases of the premature ovarian failure at very young age, mutations of several genes affecting hormone action and the follicle function have been occasionally found in humans, but none are common. And other genes such as this DNA binding protein and transcription factors and RNA binding proteins are involved in the oogenesis. Plausible causative mutations have been identified in a few women, but are exceedingly rare, only 1 to 2%. Thus, considerable heterogeneity exists in the premature ovarian failure, and no routine genetic screening can be recommended so far beyond the karyotyping. To So, in few cases, what we have seen is two of the candidate genes are located on the X chromosome. So, like these mutations or the pre-mutations typically associated with the secondary menorrhagia in the female relatives of the male patients with the mental retardation. A significant risk of the premature ovarian failure is represented by a pre-mutation of fewer than 100 CGG repeats in the female carriers of the Fragile X syndrome. This defect would represent an unusual example of an X-linked disease in which affected females inherit the mutation from their unaffected father, which has been it's slightly questionable. An opportunity to predict the likelihood of early menopause could be offered by an early diagnosis of the familial premature ovarian failure. So that is what, whenever we are able to diagnose it early, we can help these patients by helping them freezing their oocytes or freezing these embryos and having children earlier. All this counseling can be done in in this group of patients. So it is important for the clinicians to make a timely diagnosis and begin appropriate strategies for symptom management, emotional support, and risk reduction, because premature ovarian failure has cumulative negative effects over time. And karyotype evaluation and other cytogenetic investigations are useful to identify major X chromosome abnormalities in these patients. So genetic counseling is recommended for several reasons when a genetic form of premature ovarian failure is suspected or identified. Counseling is of particular importance in cases of families with the X-linked mental retardation, that is Fragile X syndrome. The expansion of CGG repeats is associated with the gene silencing, resulting in the male mental retardation and in the premature ovarian failure with secondary amenorrhea in female carriers. When a female is born from a family with other female member affected with the premature ovarian failure, genetic investigation may be useful for the early diagnosis of the genetic defects underlying premature ovarian failure. Pedigree studies on the affected female showed a mode of inheritance suggestive of autosomal dominant or the sex-linked transmission or X-linked inheritance with incomplete penetrance. So take-home message is, depending on the clinical findings, the infertile male patient needs genetic evaluation. Whenever we find the infertile male patient, genetic evaluation to be done in such a cases, at least if they are azoospermic or severe oligospermia. In these cases, at least the genetic evaluation is compulsory, and karyotypic analysis and Y chromosomal microdeletion screening should be performed in these patients with the azoospermia or severe oligospermia in order to rule out the structural chromosomal abnormalities such as the Klinefelters or the Downs and the Y chromosome microdeletions. Infertile patients with obstructive azoospermia, in these patients, we need to rule out regarding the cystic fibrosis gene mutation screening, while in patients with the hypogonadotrophic hypogonadism, mutation screening may be performed according to the clinical features. All the genetic analysis should be accompanied by the expert genetic counseling in both the male and the female patients. And regarding this female, primary amenorrhea should be investigated and whenever they have this premature ovarian failure or the primary amenorrhea. If such a patient comes, in these patients, a karyotypic analysis should be is a must, and selected mutation screening according to the patient's clinical features. Sometimes we may even see the Turner syndrome, that is 45XO, in these patients. Karyotype analysis and the Fragile X syndrome gene screening is recommended in cases of the premature ovarian failure. At present, the infertility of the patients with premature ovarian failure cannot be restored if the diagnosis is made after complete follicular depletion. But in some cases, where the early diagnosis by the genetic investigation may instead lead to the advice of the early conception or oocyte harvesting and preservation. That is what. So once after the complete depletion of the follicles, nothing can be done in these couple. So most of the patients come to us at a later stage. But once these diagnoses, when already it is familial, and if they come in the early period, they will be having the chance at least for the oocyte cryopreservation, which may be helpful for their own offsprings at the later date. But when they come to us at a very late stage, when there is a complete depletion of all the follicles, again nothing can be done other than going for a donor oocyte in such patients. In addition, the accumulation and annotations of the array CGH data might in the near future lead to the identification of the pathogenic CNVs and genes involved in the premature ovarian failure. Karyotypic analysis of both the couple is recommended in all the couples of the recurrent pregnancy loss. So that is must. And whenever we see the patients coming to us with a recurrent pregnancy loss, at least two or three abortions before 20 weeks. In all these cases, karyotypic analysis of both the partners, both the wife and the husband, to be done. And in the PCO patients, no routine genetic testing is recommended so far. So thank you. So if you have any questions, you can put it in the chat box. Okay, our first question is by Rupa. How many days after periods will start treatment for endometrial thickness for embryo transfer, or on which day of the period we should go to hospital for endometrial thickness treatment? So I think you're asking about embryo transfer. So usually we advise the patient to come on day 1 or day 2 of the period. So we'll just check out whether there is a proper shedding of the endometrial lining and whether there is any residual cyst in the ovaries. If there is no such cyst and endometrial thickness or shedding is appropriate, we subject those patients for the estradiol valerate treatment, and we'll be monitoring in a subsequent days, like once after first scan will be after 7 days, and thereafter we'll be monitoring every alternate day for the endometrial thickness. So our second question is, what are the types of genetic testing for infertility in men? So that is what, whenever we see infertile men with the semen analysis showing azoospermia or oligospermia, in such patients, we generally advise this karyotypic evaluation, Y chromosome microdeletion, and in few patients, when they have this obstructive azoospermia, where we can see the hormone profile will be normal, but still they have azoospermia, in such patients, we should ask for the cystic fibrosis gene mutation too. So third question, what are the pros and cons of genetic testing? We'll be knowing what is the causal factor for the proper, means if the patient has got azoospermia and his hormone profile is normal. So in such patients, when we are suspecting the cystic fibrosis gene mutation, and if the patient is subjected to the genetic testing and we are able to screen and find out the cystic fibrosis gene, we will be knowing whether he is an heterogeneous for that. I mean, he has got the carrier status or he is affected. We'll be knowing, and so that the transmissibility to the offspring will be known. That is how this genetic testing will be helpful. Why is genetic testing important? That is what, one is to find out the cause and whether this will be transmissible to the offspring, or the offspring will be affected, or in case in such a problem, still we will be able to get the sperms which will be, if the progeny is not getting affected, and still we are able to get, in few cases, like in few mutations, we will be knowing still they'll have this spermatogenesis, so that their sperms can be used for their offspring. When should one go for the genetic testing? In females, generally, whenever we see this recurrent pregnancy loss and or else premature ovarian failure, whether if they have a family history and if they can be subjected very early, in recurrent pregnancy loss, both the partners should be subjected for the genetic testing. And in the male partners, whenever we see in the semen analysis, if they get this oligospermia, severe oligospermia, or azoospermia. Sometimes even when we see idiopathic infertility, when there are less than 10 millions or 3 million, even in such patients, when we better to subject them for the karyotypic analysis. Can hypothyroidism cause infertility? Um, Yeah, but that depends on the means most likely if in the female patient it will be affecting the ovulation or the regularity of the cycles. In such cases, if she is not being corrected for the thyroid problem, surely it can cause infertility in few of these patients. But once this thyroid is corrected, uh, it will surely, I mean, the fertility will be reassured. So I think all the questions are over. Okay, thank you, thank you so much.